Okay, welcome everybody to this presentation on medical record documentation. The presentation tonight is going to be brought to you by the Center for Physician Resources and in partnership with MMIC. Please note that all lines have been left open at this time, but if we pick up a lot of background noise, we'll probably go ahead and mute those lines just so Robert can speak without getting all that feedback. Again, not a problem, because then what we'll do is we'll pause a couple times throughout the presentation to see if anybody has any questions. With that, I want to thank Robert for being with us tonight. He has been a true resource for us and going to lead us through a pretty interesting topic on medical record documentation and how you can try to mitigate risk with proper documentation. So with that, I'm going to turn it over to Robert.
Thanks. I appreciate the opportunity to be with you guys again tonight for the second in these series of educational programs. From a professional liability standpoint, from a medical professional liability insurance provider and someone who's worked in that profession for a number of years, documentation is near and dear to our heart for a number of reasons, and we're going to hit on those as we get started in the beginning here. But I can say that there is nothing worse for us than to be involved in a professional liability claim when we go through and evaluate the clinical aspects of the care that were rendered. We feel that the medicine is defensible, but when we look at the documentation side of that particular process of care, the documentation is either non-existent or just so poorly documented that it puts us in a position where we really can't mount a vigorous defense. And that's particularly pertinent when we're talking about physicians, because if we have a hospital claim, those tend to be a little bit easier to settle, and biting that bullet isn't as difficult because there's not as often a personal loss involved there. There may be a financial loss, but talking about a physician having a malpractice claim that ends up being settled, there's that reporting to the National Practitioner Data Bank that is a sting for everyone involved. And we never want to see that occur, especially in a situation where the medicine that we were dealing with in a particular incident was defensible. We'll talk briefly about risk management and malpractice, just a couple of quick definitions on those. And then I always like to touch on the claims environment and just give an idea as to what we're seeing out there from a professional liability claim standpoint. And then we'll talk for a couple of minutes about documentation and malpractice, and I'll make that correlation between the two and show you just how often we see that correlation, and again, how devastating poor documentation practices can be, not only to leading to a malpractice claim, but then also in putting us in a poor position as far as being able to defend it. There are 6 elements of quality documentation. I've broken out the electronic health record side of this. There's 6 or 7 slides where I mention the advantages and then risks and concerns from EHR. I strongly suspect that the vast majority of you have already moved on to utilizing EHR. And one of the documentation tactics, the basics of what we look for, will have remained the same, moving from paper to electronic, especially when we're talking about malpractice defense standpoint. But I do bring out the differences and make you aware of what we see as potential advantages and concerns from EHR standpoint. So just quick objectives. We're going to talk about ways to mitigate malpractice risk with accurate and complete documentation, and then avoiding documentation pitfalls that could be leveraged against a physician in a malpractice claim. And through all of the entire slides, we hope that you put yourself in a position where you're kind of conducting a self-assessment of your documentation practices maybe over the next week or month as you're back doing your day-to-day business. Hope that some of this that we talk about will hit home and hopefully help you provide better patient care, put yourself in a position where you're lessening an opportunity for a bad outcome in a malpractice claim. As far as medical malpractice and the definition of medical malpractice, the first 4 up here, a duty, a breach of that duty, causation, and damages, are required. It's the legalese side of medical malpractice. But what I to focus on what I mention in every single one of my programs is what we call this malpractice plus or X factor. And basically what this is it's a shift in the way that the plaintiff's bar has been approaching medical malpractice claims over the last 3, 5, 7 years. We don't know exactly when it started, but we know that it has been growing as a trend for the last number of years. And basically what this is a focus in professional liability claims that has moved away from a purely clinical approach to practice, where they were looking something that was where attorneys were focusing on, harping on, and trying to exaggerate clinical issues that had gone wrong. And what their focus now more tends to be is on the service side of medicine, basically service lapses more than non-clinical issues. Unfortunately for physicians, a lot of those things fall outside of your day-to-day purview. You are more focused on the clinical side of the medicine. What we find is these types of service lapses. The example that I always use is a follow-up systems error, where you have a mammogram that's ordered on a patient. The mammogram, you ordered it correctly. The mammogram was performed correctly. The radiologist read it correctly. Unfortunately, there was something on the mammogram, but somehow or another, after all of the clinical aspects of care have been performed, the report is lost. The report is misplaced. The call that was made to the patient somehow or another gets mixed up and given to the daughter or to the wrong patient, something along those lines. And what we find is that American juries tend to be very, very unforgiving of those types of issues. We have found more and more over the last 10 years that juries tend to be more forgiving of clinical issues. They understand that what you are involved in is the practice of medicine, but they don't think and they don't have the ability to forgive a missed phone call or an accidental misplacement of a lab report or something happening in an EHR where a report pops up and you hit the wrong button and that report disappears. Be unforgiving of those things, and what plays a major role in is proper documentation. If there is a slip-up, a mix-up, an opportunity to have prevented a patient injury that because of a failure in documentation or lapse in documentation led to that patient injury, we see juries very unforgiving. We see plaintiff's attorneys very excited about those types of cases, and they tend to pursue them relentlessly. Today's claims environment, we see that claims frequency is stable, although what we expect is that that's going to start to uptick again. That's the number of medical malpractice claims. Over the last 5 or 6 years, we have seen a decrease in claims frequency, and that has been a positive for us, for you, for physicians, for the industry as a whole. As frequency decreases, costs for professional liability insurers have gone down significantly. We've seen that trend in lowering in costs of professional liability insurance. We do unfortunately see that claim severity is on the rise, and it's not that we're seeing huge shock peaks in severity, which is the dollar value of the claims that are working their way through the system. But over the last 7, 8, 9 years or so, we have seen those times, those point in times, those 4 or 6 month periods where we see significant increases and shocking jolts in severity. And what happens is they just don't come down. And so what was a shock of a $200,000 claim inside of 6-7 months became a $300,000 claim, and then we're dumbed down by that because it never goes back down to $200,000. And basically $300,000 becomes $400,000, becomes $500,000. And because it is the daily doing, it's hard to remember the days when it was lower. And what we see now nationally, that 1 in 4 jury verdicts exceeds $1.2 million. We're a little bit better here in the Midwest, especially the farther north you get in the Midwest, but not that much better. The cases that go all the way through the jury system and the trial system When those cases are lost, they tend to be very expensive, and this kind of plays that out. What we expect and suspect is that X factor that I mentioned, that focused on the service side of medicine, is going to continue to drive that severity trend. There's a punishment factor with that focus on the service side that we feel is increasing those jury verdicts. And here are some, and these are shock verdicts. I don't do it to scare or to blow things out of proportion, but I think that it's good to know that these things, these $20.5 million verdicts, are just not that far out of the realm of possibility. The one that I actually am from and live here in Missouri, and so this last one is a little closer. We still consider ourselves to be in a protected environment from a professional liability standpoint. These are statistics of within a 15-month period, we saw 7 cases where the jury awarded the plaintiff $2 million or more. So shock verdicts, larger verdicts, a problem. We're looking to do what we can to focus on those, and one of those happens to be good, proper, sound documentation practices. So reasons for today's malpractice environment: patients' expectations and abilities. We're just seeing a different patient than we saw before. The societal view of the system, meaning the malpractice system, and societal view of a dollar. A buck just isn't a buck anymore. What was one person in California last night won $425 million and on the Powerball. And what we see is with those types of huge dollar values floating out there, baseball player, a pitcher for the Boston Red Sox signing for $138 million. Those types of dollar values dumb down the general American public's perception of what a dollar is worth, and they equate that to the malpractice system. And we see a lot of patients who have become plaintiffs who see the malpractice environment as basically a malpractice lottery. Another area where we recognize that we're seeing issues in the malpractice environment just because patients understand they have more unabated access to their medical records. IOM report of 1999 has worked wonders for us in healthcare in general, because it has focused and placed so many human and financial resources on risk management and patient safety. But if you all will recall what the headline of the IOM report was, it was somewhere between 44,000 and 98,000 patients die each year due to medical negligence. And that was devastating for us. We still are reeling from some of that fallout. Much more realistic reports, and I mean realistic geographically, realistic definitions of medical negligence were performed. That number was significantly lower than that, depending on which study. Between 15 and 22,000 people die each year due to medical negligence. But as I like to say, it's still very difficult to go on to Good Morning America and say, no, we only kill 20-some-odd thousand patients each year. One too many. And the IOM report, although it has had some positives, is still wreaking a little bit of havoc. And is again that continued focus on shift from clinical issues to service lapses. So let's talk about documentation. It's a direct relation to medical malpractice. Documentation remains in the top 6 issues leading to medical malpractice claims. For as long as I can recall, documentation has been in that top 6 of leading factors. And during implementation and early adoption of electronic health records, there's an increased risk to patient safety and malpractice. And so documentation, because of that, has crept even higher onto that list of malpractice, because we're past the tipping point now where we're seeing, full implementation of EHR across a broad swath of the country. And so that early time period of implementation and adoption increases that risk of patient injury and malpractice claim directly because of EHR. There are indicators that as you move far into the utilization and you get full implementation, that there are a number of things in an EHR that can help reduce in patient injury and malpractice claims. The jury's still out on that. For every one good one that I can point to, I can also point to a bad one. So although there may be some issues down the road, some benefits down the road that we haven't fully fleshed out, right now it's not a panacea. It's not EHR is going to stop all documentation problems leading to malpractice claims. In fact, far from it. So effective documentation additionally is a twofold malpractice contributor, and here's how that works, because clinically, poor documentation with that lack of continuity of care, with the lack of subsequent providers, of subsequent physicians and nurses coming on shift, being able to read documentation, understand the clinical issues with the patient. With poor documentation, that continuity is broken down, and so what we see is that leads to a patient injury. And the flip side is that now we're faced with a situation where we've got a medical malpractice case, and we're having to defend that case with the exact same documentation that caused the patient injury. And so it really is a snowball effect with poor documentation that once the ball starts rolling, very difficult for us to slow down and stop as far as patients getting hurt. So quality documentation is absolutely critical to the defense. It's important to remember that medical malpractice claims have the longest tail of any insurance claim in the world. Their average length of time, it says between 2 and 5 years. If you have a case that goes from occurrence to trial, the majority of those is longer than 5 years. And we're talking about being involved in a trial where we're reading documentation that was written 5 years earlier. And honestly, in a scenario like that, the better the documentation, the more thorough the documentation, the more vivid the documentation, the better the ability to recall that, the better ability to defend the doctor, the hospital, or the nurse. And documentation supports the care given and the decision-making processes that you were making, even if there was a negative outcome. It's important to remember there are risks of the procedure. And sometimes bad things happen, even when medicine and the medical care that was rendered was correct. And so it's that documentation of your thought processes and decision-making process that allows us to say, this was a risk of the procedure, here was everything that was performed correctly. And what we see is that this serves not as much as a defense mechanism as far as utilizing it to defend a claim, but more importantly, it serves as a preventative function. We would rather this never come about. And I can tell you that a plaintiff's attorney looking through a medical record, seeing sloppy documentation, inconsistent documentation, missing documentation, sporadic documentation, is much more willing to put his money on the line for a case than when the documentation is concise and consistent and accurate and flowing and explanatory. So documentation in malpractice, it does increase the filing of claims. What we find is the attorney experts look for red flags in medical records where there has been some sort of patient injury, even though that injury may not have really risen to the level of a true pursuit of a claim. So an attorney goes back and looks and says, well, this is a pretty significant injury. Don't know that there was anything wrong with the medicine. Let's go see if we can find something wrong with the documentation. We all know that it causes patients injuries directly. Like I said, that loss of communication, coordination, and continuity of care when the documentation is poor directly leads to patient. And what we find is that in documentations, the leading reason medically defensible malpractice cases are settled or lost at trial. Just as I mentioned earlier, there's nothing worse for us than to know that the medicine was good, but being held into a position where we just can't prove it because of the documentation that's available to us. As far as defense of medical malpractice cases, it's estimated that in 45% of cases that we actually go to defense on, issues with the documentation. And, that's why it's been in the top 6 for as long as I can remember. And with the EHR, again, I think that's why we're going to see this number probably grow, at least until we get past that point where a majority or a significant amount of the country is fully implemented in EHR practices. So I mentioned some of those red flags that we see plaintiffs' attorneys going in and looking at. Again, an injury may have occurred, something may have gone wrong, but in a lot of instances, it's not something that's so significant that it's an automatic slam dunk malpractice case. And so when you get plaintiffs' attorneys in there starting to dig around and see if they can't find some of these types of red flags, where some medication or some sort of treatment was ordered but it was never documented, or lack of patient teaching or discharge planning. And this is another huge movement that we're working towards, again, on the softer side of the science, where we're trying to work toward patient engagement and patient involvement. We're spreading some of the responsibility of the care that you're rendering by getting your patients on board and engaged. A positive byproduct of that is that you're working toward engagement and working toward patient orientation and patient involvement. That documentation of teaching and discharge planning and patient involvement naturally flows into the medical record. And plaintiffs' attorneys get very skeptical of taking a case forward when there is the appearance and suggestion that some of the responsibility as far as the patient is concerned was noted to the patient, told to the patient, and documented in the medical record. So it's very easy, and we see it so often happen where a patient plays ignorant and says, I didn't know that I was supposed to, whatever clinical process that may be, take my medicine, report back to the ER, clean my wound. And when you get that type of involvement and dedication and orientation with your patients, and that documentation is in the medical record, we see that shying away of plaintiffs' attorneys, because the responsibility then will have been spread onto the patient, which is where it should be. It should be a scenario where a physician is required to carry the entire load. Another red flag they look for are charting inconsistencies. You can imagine the spectrum that can cover. Less in time, especially if you've got a significant patient injury, and then we see an inpatient scenario or a scenario where a patient was in your office for a significant amount of time, and there's absolutely no documentation of what was going on during that time. Reference to an incident report. Please never put anything in the medical record that even remotely references an incident report. We've done everything that we can for years and for decades to make sure that incident reports fall outside of the purview of plaintiffs' attorneys being able to request those. And the reference to an incident report in the medical record pretty much calls it into question. And as that happens, it becomes much more difficult for us to protect it. Additionally, the suggestion of impropriety or the suggestion of something must have went wrong, if there's an incident report being filled out, puts in an odd position. Lack of informed consent, another big red flag. I know that for years we have kind of, downplayed just how important informed consent can be. From a defense standpoint, from a prevention standpoint, I can tell you it's huge. And I also think that it's a great way to begin that patient engagement, that patient orientation, that patient involvement process, especially if it's a procedure-based process of care where a patient has to sign an informed consent form. I think it's a great to start that conversation. And what we see is if there's something that was performed, something that was done, and there's absolutely no documentation, a lack of informed consent, we've got issues. I get this question a lot because there's two ways to play this. You can go through the informed consent process and document the informed consent process ad nauseum, where you've got pages and pages of what can happen to you. Loss of a thumbnail all the way to patient death and everything in between. And I know some attorneys that suggest that that's the way that you go about your informed consent process. I tend to fall to the other side for a number of reasons. I think that it seems a lot heartfelt and a lot more honest if you simply state that you have an opportunity to sit down and discuss the benefits and alternatives with the patient, ask the patient if they had any questions, request their input, and requested their understanding. I think that, in my mind, that paints a much better picture than go to a 3-page informed consent form that has, the average American reads on a 5th grade reading level. These informed consent forms are written by lawyers on a 15th grade reading level. It seems so disassociated, so cold, and so blunt that I don't know how much weight they carry. I've also seen scenarios where you list out 44 different things that could happen, and then you all know what happened. It's the 45th one. I actually saw a scenario where a plaintiff's attorney said, "So you listed the possibility of the loss of blood. Yes, the loss of limb, the loss of eyesight. You list possibility of impotence, but you didn't list whatever that other one may have been." So lack of informed consent, a big red flag, also a great opportunity to prevent as opposed to have to worry about defending. Failing to monitor or failing to act when a patient's condition deteriorates. It's the problem with documentation like this is that when you're reading it, hindsight's 20/20, and you can go back and start to read the timeline of documentation and thinking, wow, we can see where something here looked like it was going bad or going wrong or starting to deteriorate. They had a big gap in time. There isn't any further mentioning of this deterioration, and that documentation isn't there. It goes from what looked to be something rather innocuous to all of a sudden the patient's in cardiac arrest. And I understand that it's difficult in those trauma times and those times of upheaval to make sure that we're getting documentation, even if you can't do it on the spot. A quicker recollection of documenting what happened is something that can protect you. Again, another one of those red flags they look for. Battle between healthcare providers, because this is jousting or negative comments or just basically a disagreement between a physician and a nurse or a couple of physicians or a couple of nurses, and that battle gets played out in the medical record, oftentimes in an attempt to protect oneself. Huge red flag for us. The way this works is pretty simple. If the plaintiff attorney knows that one of the two people on the good side were in the wrong, their job becomes pretty easy. They just step back and watch the dollar value of that claim go up, and so we can't afford to have something like that in the record. Late entries that aren't labeled as such or appear to be self-serving, I have no problem with late entries. We'll talk briefly about it at the end. Addendums, late entries to the medical record, I have no problem with them. There are a couple of caveats that I'll throw out there. But be candid, be forthright, be honest, be above board, be as open as you can possibly be if they're late entry in the medical record. Go as far as saying, this is why this entry is late. Here's why I'm putting it in here at this time. No problem with it. When it doesn't appear to be that way, if it looks like there's some sort of self-serving nature to this late entry, fly. Fraudulent or improper alterations of the medical record, that puts us in a position where we get out our checkbook. I have never seen a full-fledged attempt to defend a medical malpractice claim where we knew that there was fraudulent concealment or improper alteration. It's a losing battle. Let's get to the point where you're trying to cut your losses at that point in time and try and keep the dollar value down as low as you can. If you can imagine how often this would be brought up over and over and over again, and it's one of those, if you'll lie, if you'll cheat, if you'll steal, then what else will you do? And so anytime that there's that fraudulent concealment, and mind you that in most states, to be honest with you, I don't know exactly off the top of my head with South Dakota, but I would suspect that it's true that fraudulent concealment is one of the only ways, from a professional liability standpoint, that a physician can end up being personally liable through punitive damages for something that went wrong from a professional liability standpoint. Destruction of records or missing records fall in the same category that we had there before. So here's my one funny. I know that it's kind of late at night. Hopefully this will lighten things up for us. Doctor says, it is a typo. So you were expecting the collagen injection in your lips and the liposuction on your hips. I can't hear you all laughing on the other end, but I suspect that you're just bellowing. So let's talk about what to document, or why to document. As I mentioned, continuity of care comes in at the very top. It's the reason that we go through the documentation process, making sure that we're able to continue that process of care, and the next physician, the next nurse, the next care provider that picks up the record is able to have a pretty good snapshot as to where they stand clinically. Quality improvement review, of course, reimbursement. These are all the things that we don't like to talk about, but that we know that they're there. Reimbursement, accreditation standards, research, and then hopefully not, but just in case, also legal defense and a professional liability claim. And so the record does remain the same. It is the legal record. It supports your decision analysis. It speaks for you. It's the old, if it isn't in the medical record, it didn't happen. What's the Confucius saying that says that the lightest ink is clearer than the brightest memory? That we've got to have that writing. We've got to have that documentation. As far as patient safety is concerned, again, I mentioned the coordination, continuity, and continuation of care. Also for quality review, if something has gone wrong, maybe not due to any particular person or person's issues, the documentation is what allows us to go back and take a look at that and hopefully keep it from happening again in the future. Along that same vein, generating data for research and trying to figure out what best practices are. If we're just guessing what happened in the past, we aren't able to figure out the best way to do things. Documentation allows us to go back and look at what worked, what didn't work, and what we can do to take that, the good things, and make them better. And then compliance with the regulations, credentialing, and there's always money involved. Talk briefly about what we see as the most frequent documentation deficiencies. Incomplete documentation of clinical information. I think that always falls in at the top. Failure to document a patient's informed consent. We had that conversation just a couple of minutes ago. Failure to document patient telephone calls. Big problem for us, especially moving into electronic health records. I took we had a couple of long claim examples in one of these programs, and I took it out. But basically, one of those claim examples, which ended up being a tragic death of a child, was due specifically to this. There were telephone calls that were coming into the office. They were an extremely busy office. It just so happened that it's the Swiss cheese model of patient injury where the whole lined up just right. One nurse answered the first call, didn't document it. A different nurse answered the second call and didn't document it. A third nurse answered the third call and didn't document it. And by the time the physician was made aware of the situation, it was too late, and we ended up with a dead child. And so if those three calls had been documented in the medical record, and then this was quick, this was within a few short hours, but if any one of them had been there, I think that it would have closed that loop and that child's life would have been saved. So after hours telephone calls, another big problem that we see where especially if you're taking call. I know we're starting to see less and less of that with the hospitalist coming into full favor and full play. But if you are taking call after hours, please find a way to make sure that you're accurately getting information into the medical record. And it doesn't have to be everything. It doesn't have to be super concise. It doesn't have to be extensive, but it needs to be something. When this is years ago now, in 2003, I believe there was a case with MIC where a surgeon was out to dinner with his wife at a Chinese restaurant. He got a call from a patient who was post-surgery. She had some sort of abdominal surgery, post-surgical. She called. She was complaining. She had some pain. She had some issues. They were enough to cause him some concern. He said, "Listen, I want you to go to the emergency room. I need you to go to the emergency room right now. Let's get you in there." And just from away from where his practice was. So he said, and I will get a call into the emergency room and see what happens. He was actually at dinner. He asked his wife for a piece of paper. She gave him a napkin from this Chinese restaurant, to which he wrote down just the basics. Wrote down patient's name, the time called, the quick question that she asked, the advice that he had given, and his plan for follow-up. Went to the office the next morning. He asked his nurse if she would put this is still paper record, if she would put this in the medical record. I think he was asking her to transfer this into the medical record. Instead, she went and got some sticky tape and taped this napkin from a Chinese restaurant into the medical record. And when we got this malpractice claim, we looked at it and at first thought, what is going on here? But after just a little bit of discussion through the office, we realized, how much more credible can this be? And 4 short lines of documentation on a Chinese napkin taped into the medical record is basically what shut this case down before it ever got off the ground. The patient had been non-compliant about what she was asked to do, and that's what ended up happening. From a clinical standpoint, everything had been done correctly. Even a small bit of documentation was able to salvage the scenario. Overlooking critical information in the medical record, it happens a lot more now with EHR. We've got a whole slide that I'll talk to you about that on. It really looks bad. If something is overlooked when the plaintiff's attorney is able to show that information was available in the medical record, no matter how hard it may have been to find and to locate, if it's there and it's located and overlooked and led to a patient injury, very, very difficult for us. Documenting an inappropriate entry into the medical record, this can be a number of things. This is making negative comments about other providers, like jousting that we had mentioned. This can be making a negative comment about the patient. This can also just be making an inappropriate entry, an inappropriate clinical entry into the medical record. Looking at some categories of missing clinical information during primary care visits, pretty staggering. And we see that these numbers have been higher, what we call the black hole effect, when a primary care physician is seeing a patient that's coming out of the hospital after having spent some time in a hospital facility under the care of a hospitalist. Significant information missing. But this is during primary care visits. 4% of the instances, lab results were missing. Letters and dictation missing in 39.5%. Radiology results missing in almost 30% of the cases. Physical exam missing in 25 or over 25. Prior medications, pathology results, immunization records, procedures. And we're talking about dealing from the start with very, very limited information. You're dealing with imperfect information because it's just not there. And then you're being asked to make perfect decisions with imperfect information. And you can imagine, again, how that cascade and that spiraling occurs. So some of these deficiencies that we talked to, what do they lead to? Obviously, patient injuries, poor documentation often prevents healthcare providers from making accurate diagnosis or rendering appropriate information. If you flash right back to this, you're at trying to help a patient and make an accurate diagnosis, but you don't have the lab result or biology results, you're in that position right from the get-go. These deficiencies also lead to malpractice claims. After a patient suffers harm, the patient's attorney will scrutinize that medical record. Incomplete, inaccurate, or illegible records may serve as the impetus for a malpractice claim, even when the care provided was not negligent. Again, can't focus on how much the impression that the plaintiff's attorney receives from the quality of documentation weighs on the decision to pursue that claim any farther. Remember, plaintiff's attorneys work on a contingent fee basis. They're making a decision whether or not they want to apply their own financial resources to try and front end the financial part of this case. So better documentation, willing they are to try to lose some of their money. And malpractice losses. The provider's care may meet the standard of practice, but the deficiencies in documentation devastate the defense of a claim to an extent that we just can't win it. So the elements of quality documentation: consistency, accuracy, objectivity, completeness, legibility, not as important as it used to be before full EHR like we're seeing, but still significant. I've got some pretty decent examples. And then timeliness. So consistent documentation. What we know is in your documentation, consistency breeds accuracy. Doing everything the same way every time, putting things in the same place every time, using the same flow of documentation every time, using the same tone every time. It is a little bit easier with an EHR to do these things because you're directed into them. And in most instances, you can go back and look at paper records where the documentation was consistent as far as pace, flow, tone, and method. But keeping this in mind and understanding that the more that you can become comfortable with that consistency, better your accuracy in your documentation is going to be. Some keys to consistency: being precise and directly precise. No redness or induration at the injection site. That paints a pretty precise picture for us, okay? Specific. Make sure you're specific. Quantify. Don't use, well, it appears to be, or apparently. Those types of words are soft and they're easy to be manipulated to mean a different thing, or to at least not be as emphatic as other words that you can use. Example here: patient stated he had sharp radiating pain that lasted 3 minutes. Very difficult to be wishy-washy or to make that appear to be wishy-washy. And making sure that you're being concise. You can use I because it differentiates your actions from others. No problem in medical record saying, I palpated the patient and this is what I felt. This is how I perceived whatever it may be clinically. The consistency chart on checklist notes, the instructions the instruction steps that were given. Avoid summarizing the care. Again, trying to keep it for being soft, much more succinct, much more direct, much more blunt is the way that we want it, as opposed to saying sections were taught by saying the patient demonstrated preparing site, injecting, and understands to rotate sites. This is the type of accuracy and of concise, pointed language that we know will fall in that category of being preventive of malpractice suits, as opposed to being defensive of malpractice suits if we don't get that far. Objective documentation. You've heard this, I know this since you've been in the field of medicine, but I think that some of it and some of the little pointers are good to go over. Document what you see, hear, smell, count, measure, perform, being specific, being concise, being pointed, being blunt in your documentation. Signs and symptoms should be factually described using your senses. And then this is one of the things that I think is most underutilized by both physicians and nurses. Utilize quotes for verbatim statements from the patient or the family. It's truly one of the most unutilized or underutilized resources available to you. When you try to tell need to think about it in the manner of you're trying to tell someone else what the patient said. And what you become in that scenario is the middleman. And you have the attention and the focus and the eyes of the jury on you when trying to tell that story. As simply saying, the patient said, and quotation marks, you would be shocked how the direction and the focus and the scrutiny, if it's a bad scenario, goes and moves directly from the health provider, from the physician, from the nurse to the patient themselves. So think about this as you're going through your day-to-day patient interactions, especially if it's a patient that causes the hair on the back of your neck to stand up. There's nothing more telling to say, well, the patient was abusive and abrasive. Well, okay, that means one thing. But what the jury sees that as, or what a plaintiff sees that as, is, well, that's your opinion. You say, the patient told me to blankety blank blank blank, in quotes, completely changes the scenario. The patient then has painted a picture of him or herself that was both the plaintiff's attorney, hopefully not, but the jury to see if we get to that point. So, some things to avoid: the subjective and or judgmental statements, your assumptions or personal opinions. It's very easy for these things to sneak in. Also very easy for generalizations, speculations, and vague words. Again, that's the soft side, the maybes, the kind ofs, those words really, they hurt more than they can possibly help. And never under any circumstances, like I said, speculate. Guessing as to what is going on. There are proper ways to document suspicions, but speculate, by rule out. This may be a scenario where we will draw labs to rule out whatever this may be, as opposed to saying this may be, or that might have or lead to something. That speculation just doesn't work really well in a documentation standpoint. Derogatory or discriminating remarks about the patient or the family. I think it's actually in here a little bit longer, or a little bit later. But I remember two huge examples of this objectivity when it came to judgmental standards. One where a physician wrote the patient, he's a work comp patient with no intention of working as long as the system supports him. And all physicians, when I've given these programs, say, what's wrong with that statement? Because it paints a pretty vivid picture. I mean, I'm sure that most of you at a point in time in your career have seen the word malingering work comp patient with no intention of working as long as the system supports him. Unfortunately, that gets, you look like the bad person in that scenario if it gets any further. So trying to be more objective in those scenarios is beneficial across the board. Don't blame staffing problems. Please don't mention staffing problems. We deal with that so often. This never would have occurred if we had all of the nurses that were supposed to be here tonight, or this patient's elongated alarm series was due to a shortage of nursing staffing. Those inappropriate in the medical record, again, is more finger pointing than anything else. Those are situations that should be addressed administratively as opposed to through clinical documentation methods. Alleged negligence by coworkers or statements regarding prior treatments. The subsequent treating physician making comments about subsequent treating physicians. I've seen that a lot. I saw that a physician wrote in the medical record that the nurse was reprimanded for error. When you end up in a lawsuit, it's very difficult to try to explain away, or it'd be very uncomfortable for the physician that wrote it to try to explain away why he wrote that the nurse was reprimanded for error. And then there's these jousting entries. Again, that's making negative comments about the care of other providers. There's that one. He's a malingering work comp patient with no intention of working as long as the system supports him. I saw another one. pediatric scenario where the physician wrote, one disciplined child presents today accompanied by her hysterical mother. And when I was talking about this at a program, I had a pediatrician in the back of the room, and he said, well, we see just the opposite of that. I thought he was talking about his patients, and I said, oh, it's great. I'm glad that you have good patients. He said, that's not what I mean. What we usually see is the whiny, undisciplined mother accompanied by the hysterical child. And I know you bellowing on the other end. I just can't hear you. So some of these judgmental things, how is this being paid for? He knows why he's here. I don't want to risk another worthless encounter with no value to the patient. Frustration tends to be what leaks in that starts to cause these types of documentation issues. And again, remaining cognizant and making sure that you're trying to stay away from them is the best way that to keep them from occurring. Housing, we've talked about it a couple of times. It's referring to the critical comments about other providers' care. We know that it directly increased risks for malpractice for all parties involved. The national studies estimate that about 7.5% of all malpractice claims are directly attributed to the type of banter or behavior in the medical record. So get briefly onto accuracy, making sure that you double-check patients' names, secondary IDs, verifying all reports, all results, and all documentation. I know that this is time-consuming. This is something that your staff needs to understand is extremely important. We see all too often where you're working out of the same name, close name, working out of a medical record of a different patient, where you think you're dealing with David Jones and you're dealing with Davy Jones. Those types of issues, as far as that malpractice plus or that X factor, are just completely unforgivable and detrimental. What we see is that severity in those issues, costs of those claims skyrocket. I know it's almost impossible to reread all of your documentation, and the advice that we try to give at MMIC is advice that you can actually apply and use. So I would suggest this to you. Read as much as you can. In those instances where the hair stands up on the back of your neck, where you've got concerns about a particular patient, I would suggest that you take a second look at that particular documentation. Very few times have I had a physician say to me, I can't believe that patient sued me. Normally it's, I knew it. And so if you have that feeling, pay more attention, give your documentation a little more scrutiny. Also in accuracy, again, making sure that we're doing the right patient, the right test, the right medication, the right lab, the right instructions. We're still facing wrong site surgery. We're still having patients that are coming in that are having a MRI when they were supposed to be over in the CT lab. Just making sure that we're doing the right thing, we're getting the patients in the right area, and the documentation that's following that is the same. Documenting about the right patient, the right test, the right medication. Some quick funnies here. Talk about accuracy. These are out of malpractice cases that we've actually had. One is on the second day, the knee was better, and on the third day, it had completely disappeared. It says the pelvic examination will be done later on the floor. The patient stated if she would lie down, within 2 or 3 minutes, something would come across her abdomen and knock her up. These aren't things that are impossible for us to defend. We all know what's being said there. It sure makes us look silly. And something as simple as this may be the deciding factor in a plaintiff's attorney saying, yeah, I'm going to go ahead and take this. The patient and the nurse herself reported passing flash. Skin documented as somewhat pale but present. The patient has been depressed ever since she began coming to the clinic in 1983. And then when she stated that she had been constipated for most of her life until 1999 when she was divorced. It's funny, comical, but not so funny when we end up with a patient injury. And again, not impossible to overcome, but much easier to deal with if it's not there. Complete documentation. The record contains specific findings, making sure that you're being objective. The subjective portions, as I mentioned, don't be afraid to use quotes. Make sure you're utilizing your clinical observations, getting those into the medical records, getting test results and any assessments of findings, also making sure that it's in the medical record for complete documentation. Standard templates guide completeness by prompting all providers and staff to include pertinent information. We are starting to see more and more of that with EHR, and I think that will be one of the biggest benefits 10 years from now from EHR. I've got an example that I'll show you here just in a couple of seconds. All blanks on a form should be completed, not applicable to this patient or situation. Again, we're seeing this both in paper and in electronic medical records. Leaving something blank when you can simply put an not applicable in there begs questions in some situations. And then again, we want to focus on the quality of the documentation, not the quantity of the documentation. We see when things go wrong, the quantity of the documentation tends to skyrocket. We don't want that to occur. We would rather make sure that we're just getting quality, solid, normal documentation. So as legibility, not as big of a deal as it used to be with EHR. We're not facing as many problems. Most of it's coming from scanning when things are being scanned in. Here it says, single most effective way to improve the medical record. It says, I do have a note from my doctor, but nobody can read it. So, policy and procedure in your practices for legibility should include all entries should be legible. Screen displays should be legible. Critical results should not use color. If you're scanning something in and it's in color and it's going to be scanned in black and white, the color, the impact, the thing that was helping you recognize that something was critical is no longer there. Image documents should be scanned in black ink. And when you're relying on color to draw your attention, and then all of a sudden that something's scanned in where color isn't part of it, it can put you into a bad situation. And printed image documents should be legible. For example here, this is a history and physical, what our risk managers call horrible and profitable. I mean, what is this? There is virtually nothing on here that's discernible. And this is the type of scan. This is scanning for the sake of scanning, and something that will get you into more trouble and is more likely to get you sued than if it were non-existent in the medical record. So you care reviewing your documentation, as I mentioned earlier. Sloppy documentation may be used to imply sloppy care. Last, as far as timeliness, let's talk about timeliness. Once the entry is locked, no changes can be made without making late entry or addendum. We talked about late entries and addendum. Late entries are identified. Addendums need to be identified. No entries are ever to be made after a bad outcome with administrative advice, and the answer normally is going to be no, no, no. If there's already been a bad outcome, if there's already been a request for the medical record, at that point in time, it is inappropriate to go back and start documenting in the medical record. The self-serving nature of it puts us in a position that it is more difficult to defend and more difficult to show honesty and candor on behalf of a physician than if that entry, than if afterwards we see all of this documentation trying to look what is like a cover-up. So, late entries addendum, it's completely appropriate if you forgot to enter notes on a particular patient, or you need to add important information after you've completed entries, or you need to clarify an unclear note or order. Here's how we consider a difference. A late entry is within 24 to 48 hours, and addendum is anything after 48 hours. So late entries, some of the problems we see with them, they may cause suspicions. Never use as a response to litigation, as I mentioned. If the litigation is ongoing, don't go back and use a late entry. Never add or alter after the record has been copied and given to the patient, because then we end up in a situation where the record that the defense side is using is different than the record that the plaintiff side is using, puts us in a really bad situation. Never correct an entry after a bad outcome, as I mentioned before. So we're running pretty tight here, Mark. I've just got a couple of more slides, and I'm going to power through them here. So EHR-specific advantages and concerns. From a patient care and med-mal standpoint, we see fewer legibility issues. Tick systems, when properly used, are great. The file systems, the alerts that you get for lab and radiology and other procedure reports, when properly used, they can have a significant impact on decreasing follow-up systems errors, which is a big problem for us. And then what we know is that we've got the ability and will continue to increase our ability to leverage data for increased quality. We deal with CRICO, the system out of Harvard, and what we suspect in the next 10 years is that we will be able to have such good, high-quality clinical claims data that data can be programmed into the EHR, whereas a cascade of relatively small events when taken by themselves start to come together, we can be alerted that, hold on a second, something that can lead to a bigger thing way before it ever gets to us. So I think that will be the largest benefit in the future of EHR. The ability to quickly share large amounts of information and the potential significant error reduction abilities. This is what I was talking about. The computer provider order entry has been shown to reduce medication errors by as much as 55%, and then this clinical decision support system, which is where that CRICO and previous claim information will come in EHR to provide significant advantages in disease management, prevention screening, failure to diagnose, and medication errors. It only works with proper use and proper data entry, but I really believe that we'll start to see some positives. This is a slide, and you can have a copy of all these slides, obviously, where it talks about the quality of diabetes care using an EHR versus a paper record, because you're looking at 4 different aspects of diabetes care, and the reminders and in the EHR, the reminders that correlate these things together and remind physicians to check on them and to remind physicians of them end up resulting in better diabetes care. And you can extrapolate this across virtually any type of specialty or medicine. The CRICO systems, by doing this, managed to do a fabulous job of virtually eliminating shoulder dystocia in the Harvard system by taking little indicators here and little indicators there, and when they all come together, then they're on alert for the potential for shoulder dystocia. It is still possible. I thought these were funny. The error is human, but to really foul things up requires a computer. That was actually written in 1978. And then this next one, the error is human, and to blame it on a computer is even more so. The big concerns from an EHR, I'll run through them real quick. This is the quick and free checklist. Checkbox documentation. It's so easy to run through and check, that you really don't know what you're checking and you're not reading what you're checking. The next big concern for me is the cut and paste or templated material can be awful for us from a defense standpoint. The lack of free flow text. We've gotten completely away from actually allowing you to dictate and to say your piece. Writing, everything becomes a checked box, everything becomes a template, everything becomes a drop down, and there's very little area for you to actually free flow and write. I would strongly suggest that you take as big of an advantage of that opportunity to free flow text, because that's where your story is told. Especially from the defense, especially from the prevention standpoint, being able to read what you were thinking and how the thought process was working. Lots of patient personalization. You will remember, any of you older physicians that were working 18 years ago, you could open up a medical record to the middle of the record, read some of your documentation, and in a lot of instances you could tell who that patient was. Your mind would go to directly who that patient was because of the personalization of your written documentation. That has virtually gone out the window. Unfortunately, your 1 o'clock appointment looks like your 2 o'clock appointment, looks like your 3 o'clock appointment. We've got to find ways to bring that patient personalization back into the fold through electronic health records. Some of them are using pictures. That's a great way to do it. Using that free flow text to trigger the reminders for yourself of who these patients are will bring that personalization back in there. Data overload, where there's just so much information that you don't know where the important stuff is. Page after page after page of blah, 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 and the one thing that you're looking for is just lost. Searching for screens, that is the ease of flipping back and forth with a paper record is something that has been lost, where you're having to dig back and forth now, going from screen to screen, and it's just much more difficult than when you'd have your finger in a part of the record back on the history and physical and then be looking at current notes, and you could flip back and forth, and it's just not as easy to do as it was. Then workarounds and alert fatigues, as I mentioned, those tickler systems are awesome. They're great to have, but if you get a tickler system for every single patient, if there's an alert for every single little medication that comes up, the fatigue that comes from that, basically it does away with any advantages that could have come from those alerts. And then last, one up and one down errors, that's where you're selecting a medication, for example, and you unfortunately or accidentally select the medication above it or below it, same sound, same name, same look. Another big concern that we have from an HR standpoint. These are all just continuations of exactly what I just went over. Some paste templated material. The VA has a study that shows that 75% of charting contains templated material, and 82% of residents' notes and 74% of attending physician notes included at least 20% of copied and pasted material. A lot of those that result in the little things we see here at the bottom. He, she issues 28 weeks pregnant. This patient was 28 weeks pregnant for 4 months in a row. Detailed description of ovaries and uterus and an autopsy of a patient that didn't have ovaries and a uterus. So that case material, an 82-year-old woman with a normal testicular exam, a 56-year-old below the knee amputation with pedal pulses equal bilaterally, and on and on. The last free flow text, as I mentioned, keeps you being able to actually tell your story. All patients look the same. That loss of personalization is remove that ability to connect with patients through your documentation, and that free flow text and pictures are one of the things that can really help. And then data overload, basically, that's what this is. It just shows the physician saying, then after all of this, the finished note is incredibly boring and fake, just line after line of mostly normal findings. I can't find the meat in other providers' notes. My eyes actually blur. I tell myself to read every word, but all the notes are 95% identical. I've missed important things. I think system produces, and you can imagine, you tell what actually happened at the visit because all the notes look the same. And we've got to figure out how to get better at that. Searching for screens I mentioned, workarounds and alert fatigues, and then those one up and one down errors. Those are the big concerns that I have. I think that we have that, unfortunately, I think we'll continue to see some issues with. But there are ways to work to fix them and to work with them. And as we head down the path, we'll see them. I apologize for going overboard. I got a little windy there at the end, but I'd be happy to answer any questions if you have any. Mark, you still there on the line?
I am here, and honestly, Robert, that this is a topic that you know a lot about and something you've had a lot of experience with, and so we appreciate you sharing your information with us. And this time, we can go ahead and open it up. If anybody has questions, all lines are open, so please ask questions.
This is Micah. I'm one pediatric hospitalist here at Stanford Children's Hospital, and we actually work with a lot of residents. Essentially 100% of our time is working with residents. Going back, so thank you for this presentation. It was really, really helpful. And I'm pretty early in my career, just graduated 2 years ago, and these are things that they don't really teach us in residency, and what's the legal outcome things part of it. So thank you for this presentation. So one of my questions is going to the red flags, where you say reference to incident report, and trying not to document this. So, for instance, say there was an incident on one patient. I had this one patient that was given medication over too short of a time, and there was concern about, kidney issues. How do you document that without making it refer to incident report?
Get exactly what you're asking. Just you can do that without mentioning the word incident report is where it needs to be. Here's what I have to say. Don't be candid. You've got to be honest. You've got to be forthright in those scenarios. And going in and say and being just factual. Am I correct in hearing that you said that they discovered that the medication there was more given than was supposed to have been given?
It was actually a pump failure. So, yeah.
Okay.
How do you document that? That's clinical.
Yeah.
Like in daily.
In that scenario, just the facts is how it needs to be documented. And say pump failure, if it was a pump failure, I think is something that you have to do in that particular instance. And be factual about it by saying it was ordered, how the medication was administered. There was a pump failure that changed the ordered administration. Here's what we have done to correct it. So
okay.
You've gone through and stated the facts. You never want to look like you're covering anything up. At the same time, bringing in mention of incident report, all you start to see then is finger pointing, going back and forth. And in this particular incident, it wasn't even another provider or nurse that was involved. I mean, this was an equipment failure, and so but at that, I mean, you're making sure that everything is in the medical record from actual standpoint. The next step is to then make sure that an incident report was filled out about this particular pump, because we've had that happen before where folks are so leery or worried about this being uncovered or discovered that 2.5 weeks later we end up with the exact same patient scenario because the problem was never fixed, and we never want to end up in that situation.
Okay, very good. All right.
Okay, question. Any other questions for Robert? Oh, sorry, go ahead.
The other question I have, this would be a great presentation for one of our rounds. So I was wondering, do you accept invitations for grand rounds or?
Absolutely. Did you say you work for Sanford?
Mm-hmm.
Okay. Actually, I am the liaison between MMIC and Sanford, so I work closely with your risk management department, and I can tell you right now that if you would like to have me come out and do this program, there's no cost associated with it. I'd be happy to come out and do it. If you can contact your Cindy Baldwin is the woman's name, and she's at corporate. She's the corporate risk. She's the corporate risk manager for all of Sanford. She's right there in Sioux Falls.
Okay.
Yeah, if you would contact her, or even I can contact her and say it'd probably be better coming from you, and tell her that you heard this program, that you'd like to have me come out and do it. I'd be happy to come out and do it.
Yeah, definitely. And then I'm getting great ideas from you because I'm trying to do quality improvement projects on our documentation, the hospitalists, the PEDS hospitalists. So I get lots of ideas from this and how we can improve our templates and things like that. So.
And actually, I do another program specifically for hospitalists, not pediatric hospitals, but hospitalists across the board. And you've got access to me too. If you ever need anything, don't hesitate to get in touch with me. You can email me, and I can help you with your research.
Okay, great. Thank you.
Yeah, and I just got to put this one plug in here so we don't, so I don't miss this opportunity. But as Robert alluded to, we have this presentation. We have some more presentations planned. What we have coming up in the future is we have a presentation planned on medical record privacy. We have a talk coming up on patient communications, working with hospitalists and dealing with handoffs. And Robert, correct me if I'm missing one. What else do we have?
Follow-up systems will be on that same one. Next one. 6 in all, isn't it, Mark? So
yeah, we have 6 in all planned. And so then, of course, all these materials, too, like after tonight, it'll take about a week, but we'll put a recording of this webinar out on the website. We'll get a copy of all the slides out there. And Robert, I hate to put words in your mouth, but I know you've always been very good about making yourself available if anybody has any questions.
Absolutely. If there's, this is what I do for a living, and if you've got any questions at all, if I can help in any way, and I've got we have a ton of resources at MMIC in general, but if not, the management patient safety community in general tends to be really free with information and with no sense in trying to reinvent something. I don't know it. It's likely that I can find somebody that does pretty quickly. So if you've got questions like that, my information is out there on the. I don't know if it's on the beginning of this slide or not, but Mark, if they can get in touch with you, I can give you my contact information, email, phone number. Feel free to call me.
And if they do want to contact us, Robert, you're not, you have no concerns with it. We can put their contact information to them, or your contact information to them, and they can contact you directly. So,
absolutely, that's fine with me.
Any other questions for Robert this evening? Okay, and then I do want to thank you again, Robert, for taking your time to be with us, to give us this presentation on medical record documentation. I certainly encourage everyone that if you do have any questions that you want to follow up with, please contact our office, and we can put you in touch with Robert. And then last closing comment is I want to make you all aware that our next program is going to be on medical record documentation. And while the exact date has not been set, that program will be coming up in May. So please be full of your emails, because that's how we'll get that information out to you all. And if there's no other questions or comments before we close, well, thank you all for joining us.
Thank you.